All right, I think it is time and
Hello,
Dr.
good evening,
Bakula
everyone.
joined. So Ashay, you can start.
Yeah. So, good evening, one and all. I'm Dr. Ashay Abhaisha, practicing pediatric gastroenterologist from
So-
Ahmedabad, Gujarat, India. I welcome you all to this international lecture series jointly organized by Indian Academy of Pediatrics and Global Association of Physicians of Indian Origin. As you know, friends, today we are going to discuss one of the most common condition, that is GI disorder in children. I take this opportunity to extend our warm welcome to our esteemed speaker, the doyens of pediatric gastroenterologist, respected Surendra Kumar Yacha sir and Dr. Anupama Chawla madam, along with chairperson, respected Dr. Bakul Parekh sir. My warm welcome to all the viewers who have joined from different parts of the globe. And at the same time, I'm also thankful to A.K. Tandon sir and President Dr. Sibbal sir for this opportunity. Friends, as you know, pediatric gastroenterology is now a flourishing branch. With the availability of vaccines and better standard of living, our focus is now shifted from infection to non-infectious conditions like a food allergy, reflux disease, constipation, metabolic disorder, or even a malabsorption syndrome. I am sure with the vast experience and expertise, we are going to be wiser at the end of the day. I also request all the viewers to send their questions in a chat box, which will be taken at the end of the session. Now, it is my proud privilege to introduce today's chairperson, Dr. Bakul Parekh sir. I am extremely delighted to introduce Bakul Parekh sir, who is very humble and down to earth. Sir has multiple heads over him. Sir is President of International Pediatric Association Congress 2023, Honorary Secretary General of South Asia Pediatric Association, and a Global Academic Convener of Global Association of Physicians of Indian Origin. Sir is the past National President of IAP and also the past National Honorary Secretary General of at Central IAP level. Sir has published multiple publications and has been confirmed with many awards. Over to you, sir. I welcome Bakul Parekh, sir. Please, sir.
Yeah, thank you, Dr. Asay, for your kind introduction. Good morning, good afternoon, and good evening to all the viewers and all the faculties on the screen and off the screen. Let me tell you that this GEPIO IAP webinar series is a very, very popular series, and it is being attended by many members from all over the country. As you know, GEPIO is a Global Association of Physicians of Indian Origin, having members from 54 countries. As Dr. Tandon and Dr. Anupam Sibbal has been very active in making this GEPIO IAP webinar a very successful one. Regarding IAP, as all of you know, we have 35,000 life members and a very, very reputed association, and one of the second largest pediatricians association in the world and one of the largest in the country. And let me tell you that today's webinar designed, planned is quite a long time to make it very successful. Today we have got two eminent speakers to take you through the journey of these gastrointestinal disorders. First, I will invite Dr. Anupama Chawla to give a talk, and before that, I will like to introduce her. Dr. Chawla is graduated from Lady Hardinge Medical School in New Delhi and has completed post-graduation, and has completed her post-graduation in pediatrics from England and diploma in childhood health from Royal College of Physicians, Glasgow. Dr. Chawla completed a residency in pediatrics at Stony Brook University Hospital and her fellow in pediatric gastroenterology at North Shore University Hospital in New York. Dr. Chawla is presently board confident in pediatrics and certified in pediatrics and gastroenterology and board certified as a physician nutrition specialist. Dr. Chawla is director of pediatric gastroenterology and nutrition at Stony Brook University Hospital in New York. She is dedicated to promoting children's gastrointestinal health and nutrition and actively involved in clinical research involving varying aspects of Children's Gastroenterology Health. So over to you, Dr. Chawla, for your talk. Thank you very much.
Thank you, Dr. Parekh. Thank you for the honor for having me here. Let me try and share my screen. Is that good? Yeah. So I was invited to talk on the diagnosis, management of gastroesophageal reflux in pediatric patients. And this is a very common problem. And as you stated, a lot of focus of GI has moved from infections now to these chronic ailments, some self-created and some now being recognized. The goal of my talk, or the learning objectives, will be to understand the physiology and the natural history of GERD, to review the signs and symptoms related to GERD, to describe some of the diagnostic approaches, and to explain the various treatment approaches, medical as well as surgical, to characterize the possible relationships of GERD to systems outside of the GI tract as well. Some of the physiology of reflux that prevents reflux is a good lower esophageal sphincter pressure. The crural diaphragm plays a significant role in the formation of this pressure. The phrenoesophageal ligament creates this angle of His, and in neonates and infants with reflux, they have a significantly shorter abdominal esophagus than subjects without reflux. And this is important where you do have a abdominal esophagus present, which prevents reflux. And this is the basis for the surgery that, if needed, that occurs. What about the pathogenesis of this reflux? The main factor that plays a role is the constant transient LES relaxation. This leads to reflux several times from the lower esophageal sphincter. Some of the secondary mechanisms are increased intra-abdominal pressure, decreased gastric compliance, decreased gastric emptying, and reduced esophageal capacitance that can be seen in certain autoimmune diseases as well as from chronic inflammation. And mechanisms of airway complications, especially extraesophageal complications, can be secondary to vagal reflexes or impaired airway protection. And these are what leads to a lot of secondary extraesophageal complications. Not being able to advance, why? So just to summarize the symptoms, as the talk time was short, this is a very nice graph that tells you age distribution of the symptoms as well. And as you can see, the green or the lime colored bar is children 1 to 5 years of age. The purple color bar is 6 to 11 years of age. And the gold is 12 to 17 years of age. And there is a marked difference in the symptoms, especially in the lime color bar that is 1 to 5 compared to children 6 to 17 years of age. Cough is a predominant feature in younger than 5 years of age, as is feeding refusal and anorexia, and therefore failure to thrive. And regurgitation as well as is more common in patients with a younger age group. Abdominal pain is not significantly different, but heartburn is definitely a feature of older children greater than 5 years of age. And these are the symptoms one should look for when dealing with different age groups. There are certain conditions that should really raise a red flag that in these conditions, reflux is much more common. Cystic fibrosis, which I know in India is now becoming increasingly recognized. Patients who have had esophageal atresia surgery, especially neurologically impaired children who are G-tube dependent or not as mobile. Patients with hiatal hernia, and a rising global population that is occurring in children, obesity. Obesity has become a huge factor when dealing with patients with gastroesophageal reflux in children. Whether this is their eating habits, lifestyle changes, or it actually is the function of the sphincter itself remains unclear. This was a very elegant study of almost 700,000 patients from 2 to 19 years of age, and they found almost 1.5 to 2% of these patients had reflux. These are all obese patients. So sometimes it's not just the reflux that has to be addressed, but rather the underlying condition itself. I apologize, my forward button's not working. I've got to put next each time. GERD must be addressed, must be recognized, because there are significant complications that can occur. And here are some of the photographic projections of these complications. The first one showing erosive esophagitis, which can definitely lead then to stricture. And this, the one at the bottom are later complications, are the Barrett's esophagus, where you see these salmon-colored projections into the squamous epithelium, and then the adenocarcinoma, which can occur much, much later in childhood, but it definitely can occur in childhood. So what does one do for the diagnosis? Symptoms and signs must be recognized, and of course, there is testing available. So the symptoms that are most commonly seen that should raise a red flag for GERD are recurrent regurgitation, weight loss or poor weight gain, and this is in the younger population, as I said earlier. Infants are present with severe irritability, rumination behavior, heartburn or chest pain in older children, and rarely hematemesis, but this can also be a presentation, especially in erosive esophagitis, dysphagia, wheezing, stridor, cough, and these are some of the factors that should be symptoms that they can present with. The signs that you recognize in these patients are esophagitis, strictures, Barrett's, and extra esophageal manifestations of pharyngeal inflammation, hoarseness of the voice, recurrent pneumonia, and dental erosions, feeding refusal, or even apneic spells in infants can be a presentation of reflux. Some of the warning signs that should really make you think about non-GERD diagnosis, even in the setting of vomiting, are bilious vomiting, consistently forceful vomiting. That is not typical of reflux. Hepatosplenomegaly should point towards an underlying metabolic condition as the cause for reflux. GI bleeding is uncommon. A bulging fontanelle in a child is uncommon. Nocturnal vomiting, in my GI career, I have picked up 5 brain tumors in my career. That's a lot. So nocturnal vomiting should be a red herring that this is something more than reflux, and look for it. And some of the others are failure to thrive, constipation, genetic and metabolic syndromes. And these are some of the masqueraders of reflux that can be easily ruled out, especially in the younger population. Pyloric stenosis picked up very well with an ultrasound, malrotation easily picked up with upper GI, and a bilious vomiting. As I tell all my students, a bilious vomiting in a child is not reflux and must rule out obstruction before moving on with just putting them on anti-reflux medications. And in older children, we do see achalasia that can present with the recurrent vomiting episodes. So testing for GERD has become very commonly used. Is it really necessary to diagnose reflux? More often it is done testing. In my career, I do testing more often to rule out underlying causes rather than actually diagnose reflux. And I also use it sometimes when it is what we call silent reflux, but there are so many extraesophageal symptoms, and that's when I will use the testing to see a correlation between extraesophageal symptoms and reflux. Does it guide our management? Clinical assessment is still the best guide. it is helpful and definitely helpful in refractory cases. What are the testing modalities that are available to us? I'll go through these briefly. This is a Bravo capsule that can be used in older children, say 15 kilos and above. It's a miniature pH capsule. There is a pH probe that is sitting at the bottom of this. It really comes out into the esophageal lumen, and this can be attached to the wall of the esophagus. The advantages are it's more physiological. You don't have a catheter sticking out of your nose. It can be monitored for 48 hours to 96 hours, and it can usually be tolerated much better than a catheter from the nose of a young child, which is usually, in my experience, a 2 to 3 year old will pull it out right away. The disadvantages are it requires heavy sedation for it to be placed, cannot be performed in very young children. It is costly, can cause chest discomfort, and at times when it dislodges, it can cause obstruction, and at times it has to be removed endoscopically because it does not detach. So another disadvantage is that it has to, you have to really take the patient off acid suppression, as the main thing it is measuring is really the pH. This leads us to the next test, which is multi-channel impedance catheters. This is, you do not have to take patients off acid suppression because it is a pH independent method. It measures changes in resistance to electrical current flow between two sensors. 7 sensors are present throughout the esophagus. There is one distal pH probe, and some of the new probes now have come up with some of the new impedance catheters have come up with 2 pH probes, one more proximal and one distal. There are 3 sizes available: infant, pediatric, as well as adult. This is what the impedance tracing looks like. And as you can see, there is a gastric pH monitor in the stomach. There's an esophageal monitor. This is a 2-probe impedance catheter. A lot of them do not have the gastric monitor with them. And then this is the tracings that you see in the esophagus. And this can be expanded to every 5 minutes so that you can really look for reflux in very short segments. And the parents are asked to mark events. These stars is where the parents have pressed the events, and you can see whether these are actually correlating with reflux or they are not, have nothing to do with reflux, and we are overcalling these episodes. This is what a graphic of the same monitoring looks like, and this is something some of us are more familiar with. The advantages are it detects non-acid reflux, which is ideal for postprandial reflux. It differentiates reflux from swallows, and it is able to accurately assess the full column of the esophagus. Sensitivity of the pH impedance comparable to the pH probe in untreated patients, and surpasses the old pH probe that used to be used that only measured the pH, and anything from apple juice to orange juice used to really mess up our results. This has the advantage or significant advantage over that. Of course, the limitations are there are normal values are not well established, although they are getting more and more available. And it's very time consuming to read these studies if you do it properly. And of course, there's a catheter sticking out of the nose, which really impedes how the child behaves during the study period itself. Then the upper endoscopy, the advantages are that it enables visualization, it enables biopsy so that you can differentiate from, say, eosinophilic esophagitis to actually reflux esophagitis, and sometimes even infectious etiologies. The disadvantage is that it needs a need for sedation, anesthesia, and there is poor correlation between endoscopic appearance and the histopathology. Relationship between esophagitis and extra esophageal symptoms is also not clear, and it is very costly and time invasive. Then there's the upper GI again. I use an upper GI never to diagnose reflux. I use this mainly to rule out other anatomical abnormalities such as malrotation, strictures, achalasia. And it does not really differentiate pathological reflux from just physiological reflux. Some places are still using gastric emptying scans and milk scans. The advantages are that it does detect acidic as well as non-acidic reflux. It may demonstrate aspiration and can be assessed liquid as well as solid emptying. The limitations are there are very low standards available, and the period of observation is only limited to that 5-minute period when you're 1 hour period when you're actually doing the study. Management of these patients can be conservative or pharmacological. Some of the conservative measures for GERD management are weight loss in the case of overweight or obese patients. This is extremely important. Avoidance of caffeine, tomatoes, spicy foods, and extremely citrus foods or very deep fried foods that delay gastric emptying, as well as caffeine-containing chocolates. At night, no food or meal at least an hour before they go to sleep, and smaller, more frequent meals. These are some of the conservative managements. Positioning also helps these patients. Raising the head end of the bed is helpful, and left decubitus sleeping position is also found to be helpful. And I cannot emphasize again, if there is significant secondhand cigarette or tobacco smoking, this should be strongly discouraged. And at least 90% of my patients will say they never smoke in the house. And yet when I enter the exam room, I can tell this is a smoking family. Positioning of the infants, we've all heard about SIDS and how we should not lay the patients prone. However, prone position, flat prone position is significantly better than the supine position when it comes to managing reflux in infants. Prone position is acceptable if the infant is observed and awake, especially in the postprandial period. And prone position during sleep should only be considered if the risk of death from GERD significantly outweighs the risk of SIDS, but usually this is discouraged. Prone position can be used after 1 year of age, as the risk for SIDS is negligible. What about thickening of the formula? This is something I do use. There's literature all over on this. Some discourage it, some encourage it, but this is a study that shows that not only will it help the caloric density of the formula, it also decreases the emesis, and the sleep time will increase as well, which directly corresponds to parents' quality of life. And the crying time also decreases significantly. How about pharmacological therapies? Very often, at least in the US, even general pediatricians have started prescribing pharmacotherapy quite often, and it's not always necessary. The modalities that are available to us are antacids, H2 antagonists, proton pump inhibitors, prokinetic agents, surface agents like sucralfate, and then GABA B agonists like baclofen, which really should be reserved for neurologically impaired children. This is an old study and a relatively new study that shows you the benefits of H2 antagonists on the healing of the esophagitis. And this is very significant. You can see with Axid, which is nystatin, there was a 69% healing compared to only 15% in the placebo group. The available H2 antagonists and PPIs that are available to us are cimetidine, famotidine. Ranitidine has been taken off the market completely, and the most popular one that we are using right now is famotidine. And the proton pump inhibitors that are available, here's a list of them. And the most common one that we are using, because we are able to put that into a liquid form, is either lansoprazole or omeprazole. These are the two we are using. The doses can be looked up, and because of the short time, I did not go into that in depth. In otherwise normal infants with unexplained crying, irritability, distress, there is absolutely no evidence to support acid suppression. These are normal infants who might have colic, and this is not needed. If indeed the irritability and your suspicion of this being due to reflux is significantly higher, a therapeutic trial with a PPI should be used, and the smallest, most effective dose is helpful. Usually our starting dose is anywhere from 0.5 to 1 milligram per kilogram per day, and this can be given once a day or twice a day. A single dose is administered about half hour before breakfast, and if a second dose is required, about a half hour, at least 8 hours from the first dosage. So medical management summary is that H2 antagonists do relieve symptoms and mucosal healing, used judiciously. PPIs are superior to H2 antagonists in healing and erosive esophagitis. There is insufficient support currently on the use of prokinetic agents, and metoclopramide has fallen off favor completely, but rarely it is used in some of our handicapped children. Erythromycin is another medication that is used as a prokinetic agent, but the evidence is very poor. And only in patients, anti-reflux surgery should be considered in children who have failed medical therapy for GERD. The surgical intervention is required in patients who are dependent, or either they failed therapy or they are dependent on aggressive and prolonged therapy. And in my view, the prolonged therapy is at least a couple of years and longer. And sometimes this is also used in patients who have persistent extraesophageal symptomatology. This is the surgical procedure that is done. It is commonly known as Nissen fundal plication. They restore the intra-abdominal segment of the esophagus. They approximate the diaphragmatic cura. They reduce the hiatal hernia if it is present, and they wrap the fundus around the LES to reinforce anti-reflux barrier. Some of the extraesophageal complications that you must think about are Sandifer's syndrome. Sandifer's syndrome can be picked up by neurologists, and these poor patients are going from specialist to specialist, and it is really related to reflux and dental erosions. Some other possible associations are bronchopulmonary symptoms, laryngotracheal and pharyngeal symptoms like chronic cough, chronic laryngitis, and chronic or recurrent sinusitis episodes, recurrent otitis media, and in infants, especially in the neonatal ICU, when we are called pathological apnea, bradycardia, and some of these life-threatening events that occur in the neonatal ICU. I just want to take 5 seconds to go over Sandifer's. This has been, I often get these patients from our neurologist, and the patients have been, they are severe head posturing, head tilt, torticollis, and they almost mimic seizures or infantile spasm at time. Recognize this, and if it is very rewarding if this is recognized by us as gastroenterologists and treated. This is one patient where I would strongly advocate that testing should be done because they often have silent reflux. So just to summarize, I hope I did not shoot over time much. GER is common in healthy infants and usually resolves by 18 months of age. GERD can present with variable symptoms in children at different age groups, and these symptoms vary. Currently available tests often do not conclusively demonstrate a relation between GERD and specific symptoms, although this has much improved with the availability of impedance studies. A good history and clinical judgment are important for optimal evaluation and management of these patients. There is current evidence that supports the use of anti-secretory to treat reflux-associated esophagitis in all groups. PPIs are superior to H2 antagonists with respect to acid suppression and healing of erosive and non-erosive esophagitis. Treatment effectiveness for other GERD manifestations is not well documented. However, as anti-secretory agents reduce esophageal acid exposure, they are likely to be useful in GERD-related respiratory disorders. And this especially, I find that helpful in our neurologically impaired children. I hope I answered some questions and I raised some questions. Thank you for your time.
Thank you, Dr. Anupama Chawla, madam, for the wonderful talk on GERD. And after the next session, we'll take the question and answers. And I'm also happy to share that more than 250 people have joined on IAP platform and many more on this JPO platform. So enjoy this scientific feast. Now,
Thank
I
you.
would like to welcome Dr. Surendra Kumar Yacha, sir. Sir is the teacher of teachers. Sir has completed his MD in pediatrics and DM in gastroenterology from PGI Chandigarh and fellowship in pediatric hepatology from King's College London. Sir is currently director and head of department in pediatric gastroenterology, hepatology, and liver transplantation, and head of academics at Sakra World Hospital, Bangalore. Sir is a former professor and HOD at most prestigious institute, SGPGI, Lucknow. Sir was the founder president of Indian Society of Pediatric Gastroenterology, Hepatology, and Nutrition, and was chairman of Pediatric Gastroenterology subspecialty of Indian Academy of Pediatrics from October 2002 to January 2007. Sir has published more than 215 research publications and has been conferred with 95 awards. And Sir was the one in India who started the DM project in India. I welcome you, sir. Surendra Kumar Yacha, sir.
Stuck up somewhere. Just a minute, just a minute. Yes. I'll start from here. Are my slides visible?
Yes, sir.
Okay. Thank you very much, Dr. Shah, Dr. Bakul Parekh, Dr. Tandon, Dr. Anupama Chawla, and dear doctor friends who will be listening to our deliberations today. I'm grateful to all of you for this opportunity. I've been given actually two segments to talk about: lactose intolerance and celiac disease. And extensively, I cannot cover all both the topics in short period of time, but I will give you the clinical perspective and its utility in practice about both the conditions. Now you see that there's a lactase enzyme which is located over the top of the villi in the small intestine, and the levels of lactase enzyme are basically high at birth, and they keep on decreasing by the end of infancy and with the advancing age, that means including the childhood and also the older patients, there's a non-persistence which is called hypolactasia. So the levels go down after infancy and they persist for a long time. Now here you can see there is another group with a small subgroup of patients who may have subjects who may have lactase persistence, and is genotype based. There are regional differences from country to country and region to region. What is important? This hypolactasia should not alarm you. This is basically 70% population overall has got lactase persistence, non-persistence, meaning thereby 25 grams of lactose can be digested by any of the subjects. That means 500 ml of cow's milk can be taken easily per day. So that is the non-persistence of lactase enzyme. Now you see lactose load in diet, mainly in newborn or in the infants, comes from the mother's milk. It gets converted by this lactase enzyme into glucose and galactose, and these are absorbed in the small bowel. Now, in case the lactase deficiency is there, somehow it gets decreased, the unabsorbed lactose is delivered to the colon. And in the colon, what happens? It is getting converted into hydrogen and lactic acid and also methane. And the bacteria, as we know, in the colon is terrorized power 12 per cubic millimeter on average, and they act on this substrate of unabsorbed lactose and produce the acidic stool and osmotic stool. That's why they have got diarrhea. They have got anal excoriation because of the acidic nature of the stool. Now, lactose load and breastfeeding. Human milk contains about 7.5 grams per 100 ml of lactose. Cow's milk has somewhat less, 5 grams. So the highest content of lactose is the human milk, that's the breast milk. A term infant digests around 70 grams of lactose per day. That means 1 liter of breast milk is good enough to digest by an infant. Breast milk can produce physiological lactose malabsorption. You must have seen some of the babies or infants, they have got increased frequency of the stools. Mother may also say there is some excoriation, but you should not fiddle with that. Basically, when the lactose is delivered to colon, there is a release of short chain fatty acids, and these fatty acids have an immunological benefit to the baby. That is very important. Therefore, we should not unnecessarily reduce the lactose or stop the lactose in these babies. Another important thing, just to understand, lactose intolerance, there are 4 varieties. Not to go into detail. Developmental lactase deficiency. It occurs in premature babies, less than 34 weeks. Congenital lactase deficiency. It is very rare. It is a severe form of diarrhea and it is autosomal recessive. Forget about this. Lactase non-persistence, as I explained to you, 70% population, but generally it is not below 5 years of age, so much reduction in the lactose. And very importantly, we have to understand secondary lactose intolerance. Secondary lactose intolerance is very important, which I will dilate upon. In my own study, in 1993, very old study from Vijay Chandigarh, 33% had protected diarrhea, and 73% of these children were less than 2 years of age, meaning thereby the brunt of lactose intolerance actually occurs in prolonged diarrhea, actually occurs in children who are less than 2 years of age. Many a times we have confusion, and I have seen in my own practice here that people are confused, doctors are confused about cow's milk allergy and lactose intolerance. Now, what is the difference? Cow's milk protein allergy, as we know, it's a milk protein allergy. Milk is a protein in milk, and lactose intolerance is basically an enzyme deficiency. It is not an allergy. Symptoms in the cow's milk protein allergy can be GI symptoms, which may be bleeding per rectum, which may be diarrhea or a mixture of the two with systemic involved. That means they may have eczema, atopy, urticaria, they may have respiratory problems, they can have. And that is the IgE mediated. IgE mediated in India, as per our studies, is not that common, but non-IgE is more common as compared to IgE mediated. They have second manifestation, lactose intolerance, anal excoriations. Elimination of milk and milk products, that because we have to eliminate the protein, is in milk protein allergy. Reduced lactose or elimination is important for lactose intolerance. I would say more of reduced lactose rather than complete elimination is essential for the treatment. Prognosis wise, this is the mistake which often the doctors do. Cow's milk protein allergy, once diagnosed, you have to and you are sure about it. You have to restrict milk protein for a period of not less than 1 year, and very importantly, it may go by 1 to 3 years following elimination. Normally, what we have found in children in India, 1 year is good enough, total elimination. But lactose intolerance, transient up to 3 weeks. So you should not actually restrict just for 5 days, 6 days, 7 days, because the enzyme lactase takes time for maturity on the will stop. That means around 3 weeks is the maximum time when you can have the maturity of the lactase enzyme. You can easily introduce lactose at that period of time. Another important, I will just show a case, simple snippet. 11-month-old boy on cow's milk, acute onset diarrhea for 5 days, medication for 7 days, no relief, increased stool frequency 10 to 14 times a day, explosive stool. They cause a lot of noise, there'll be excoriation and hospitalized. You see, this is when you examine, you should always examine the bottom. Don't feel lethargic in getting up and seeing this area. This is what you can see here. There is perianal erythema in this child, widespread, minimal lesions on scrotum. This is very important because this may differentiate from the fungal infection. Next, you can see this is fungal infection, fungal rash, perianal erythema and satellite lesions, more on the scrotum rather than on the anal region. So curdy white lesions, which will, if you try to remove them, there will be a lot of excoriation down. So that is how you differentiate between secondary lactose intolerance or sporadic fungal rashes. Cornerstone, it is not marketed formally, which are important. Dietary therapy, India lives in rural sectors. India is a poor country. India is more or less, we can say, not poor actually, not that rich. So you cannot afford all these 10 formulations. Therefore, my own take is that we should go for low lactose diet. What is that diet? You can simply make it at home. Very easy and hygienic. Now what is that? That is simply milk, sugar, puffed rice powder, water, oil. This is the formulation is given in many of my many chapters where we have written on the recommendation also on the diarrhea. It has got adequate calories, it has got adequate protein. And this is very effective. Actually, all the studies have shown that you should reduce the lactose, you should give cereal-based milk. That is how it can get reduced. So it becomes palatable, more consumption, quality proteins, faster weight gain, micronutrients, and all the parameters like stool weight and weight gain and treatment failure are much better with the cereal-based items as compared to just total elimination of milk. If the patient does not respond for 4 to 5 days, then you can go for lactose-free diet, which is instead of that milk, you put egg white or chicken puree, puffed rice, and you put glucose. Glucose should not be more. Glucose is a highly osmotic agent. It will produce diarrhea. Never ever prescribe glucose or glucose solutions or glucose in acute diarrhea or persistent diarrhea. Water and oil, and it gives a reasonable amount of calories and protein. So this is usually not required. Diet is good enough to reduce the lactose load and it will heal the child. Very important slide. The connect. Many conditions, prolonged diarrhea, food allergies, persistent infections of GI, malnutrition, without any other problem, malnutrition, primary malnutrition, superacute infection like fungal, celiac disease, which is today our topic of discussion, Crohn's disease, all will produce a brunt on the small bowel mucosa injury takes place. When the injury is there will be villus atrophy, loss of brush border enzyme. The first enzyme, the first hit in the brush border is the lactase enzyme. That's why they have got this problem. Now, secondary lactose intolerance does occur because of that. So it will result in malabsorption, hypovolemia, bacterial growth, then it becomes a vicious cycle. So we have to somehow treat it. Treat the cause, whether it is celiac disease, whether it is an infection, whether it is malnutrition, allergy, or some other. Then if you treat the cause, automatically the reversal of lactose takes place. So that is very important. The primary cause has to be treated effectively, and you should be sure about the diagnosis in this patient. That is about lactose intolerance. Here I will finish lactose intolerance. You can raise the questions which I may answer at the end. Now regarding the celiac disease. Celiac disease, first I described this belt in 2006, which was published in Journal of Gastroenterology Hepatology, with an international journal. This is the belt in India, and there are also now emerging areas like what we find in Karnataka also cases, Tamil Nadu, Jammu and Kashmir, Northeast, these are now appearing. And more the awareness, more search, and more cases are being diagnosed. Now, celiac disease, very important. Prevalence of celiac disease has to be noted. When to suspect celiac disease as a clinician, always remember it's a lifelong gluten elimination. Don't take it casually. Don't just stop wheat for the sake of stopping and getting a good outcome and good practice. No, that you are doing disservice to the nation. It's a lifelong gluten intolerance, and you should know that it is not allergy. Always make the diagnosis with certainty. You should be sure about the diagnosis. I will tell you how you should do in India. Then is the question of counseling. Then is the question of compliance of gluten-free diet. Then we have to also look for the complications if they are there in the children. You see, this is the data of 2020, North versus South India. The highest prevalence in India is in the northern belt, 1.2% versus the prevalence in South is 0.10. And genetic susceptibility, as we know in celiac disease, this susceptibility is not different in South and North. These are the studies. And what is the difference? Difference is consumption of wheat-based cereals. 455 grams per day in North, 25 grams per day in the South. But I'm sure it will show up because now the fast foods are coming. People are consuming from outside. Even southern population will start showing up celiac disease after some time. So we should be aware. But this is the status as of now based on Indian studies which are published in international journals. What is the classical presentation? Classical presentation in children. Three important things we should remember. Chronic diarrhea, anemia, which is not responding to our oral iron or any iron preparation. The patients are not responding. They again develop anemia. Failure to thrive or growth failure. The height, weight are affected. This is a triad. They may have also nutritional deficiencies we should internally look for. Water soluble vitamin deficiencies, fat soluble. I have seen patients who had presented with rickets, with vitamin A deficiency, with what is called the vitamin K at times may be there. India, we had a pool data of 407 cases around 5 years back, and this triad was prevalent in them. However, you should also know that celiac disease is not only an intestinal disease. It's a disease of whole of the many other systems in the body. So we don't say we have extra-intestinal manifestation also. Like you may have non-diarrheal disease, non-diarrhea, no diarrhea, but anemia, rickets, frequent fractures, particularly in adults, they are fractured, or they may have short stature. They may have associated diabetes mellitus. If any child with diabetes mellitus comes to you and endocrinologist sends to you and they are failing to grow, despite a good compliance, think of celiac disease always. And you can simply do it. So a few screening tests. They may have ataxia. They have delayed puberty and infertility. In liver also, you can have the selective transaminitis. That means OTPT, IgOT, IgPT may be elevated and you are finding the cause like hepatitis B, C, autoimmune, Wilson, whatever. But always keep in mind, in the absence of liver and spleen, look for celiac disease in these patients. So transaminitis is one of the manifestations of celiac disease. So if we don't treat, what happens? There's a big storm which will take place. I have seen the storms. I have not shown you the pictures. I have seen storms around 10, 15 years. I have published nearly 20 papers in celiac disease, which are internationally and nationally published. And on the task force, I have been on many Indian task force, ICMR task force, and we have devised some of the strategies for celiac disease in India. You can see they can develop catastrophe. They can develop intestinal lymphomas, malignancies later in the life, which is dangerous. They may have bone problems. Many other things happen in them. Therefore, we have to treat them effectively. The storm of celiac disease will cost lives if not treated appropriately. What is the problem? There's a frustrating difficulty. I also faced this difficulty, was at Lucknow also, at Bangalore also. The greater awareness, we have created awareness throughout the country. Models are there, IAP module, adult module, so many things are there. Greater awareness almost achieved in India, but a big problem faced. What is that problem? Diagnosis is arbitrary. Confirmation not done before starting gluten-free diet, half-hearted approach. Most of the doctors just do TTG, tissue glutaminase test. IgA positive, more, start on gluten-free diet. That is not the right strategy. What is the right strategy? I will tell you. See, ISPEGA, European Society, is actually the last criteria. They have confused the world. And before that, it was wonderful criteria. I know we have used it and we are still using. In American societies, adults, European society is not in favor of doing the endoscopic duodenal biopsy. They want TTG more than 100, followed by EMA positivity, followed by HLA DQ2, DQ8. If positive, all the three, then you are celiac disease. But in India, our task force in India, ICM, Indian Council of Medical Research, where I have been a part of it, and we have advocated that for Indian settings, clinical suspicion serology, if TTG IgA is positive, go for duodenal biopsy. It is very easy, very simple, 5-minute job, and easily available now all over the country, and this will give you a clue. Now, I have seen situations where TTG IgA reported to be 200, 300, and when you do a biopsy and repeat TTG from another lab, you find that is normal and biopsy is also normal. So TTG alone, high levels, in a given situation may not be right. Just bang, it is only a screening test, not a confirmatory test. Remember, very important thing. TTG, as I have shown here, should be the first line testing to screen for celiac disease, TTG IgA. If you have strong clinical suspicion, TTG IgA is negative, go for DGP. Deamidated gliadine peptide has to be done, which is available in India. They do both IgG and IgA, and you can get a clue. It is also very good. It is IgG mostly, which is very important. So sensitivity and specificity is good. Wherever you are suspecting your TTG, you have IgA deficiency. See, in India, I don't know about the West. So IgA deficiency is very low actually in celiac disease. And if you have to see the level, what should be the level? It should be less than 5 milligrams. Our laboratories in India give 25, less than 25. Whether it is less than 5 or not, we don't know. Is it 5 to 25? We don't know. Therefore, you do not too much bank on this IgA levels. Rather do TTG, IgA. If suspicion is very strong, go for DGP, IgG levels. That is the recommendation as of now. Serology varies from labs. No validity problems. Therefore, endoscopic duodenal biopsy, you should take 4 biopsies from the second part of the duodenum, at least 1 biopsy from first part of the duodenum, D1. And don't do more than 1 because the duodenal wall in D1 valve is very thin, and don't try to do a lot of handling there. Counseling, very important. Counseling is equivalent to compliance. Compliance is based on your counseling, how you counsel them. As we know, it's a lifelong gluten-free diet. Dedicated, extensive explanation of diet is required in them. How do I do it? And role, family and patient should be addressed. If there's an older child, you can address to child also and to family also. They are listening, very intelligent. Children are intelligent these days. Other family members, we know we have joint families, concept, grandfather, grandmother, maternal, all these uncles, out of love, they will give something to the child. They have to be told, either by the family members to tactfully that we have not to consume these food items, and also either if possible, the doctors can themselves stop. I don't go to the dietitian and tell you counsel. No, I don't. I will do counseling myself. I've seen hundreds of celiac disease patients. Counseling, your own counseling, spending time with them is very, very helpful. I have seen compliance in majority of the patients in celiac disease. Good compliance, because the mothers are dedicated in India. They will do anything possible for the child, whatever. That is a great advantage in this country. Adherence to gluten-free diet is a challenge. I show this diagram to every celiac patient. 1 gram of gluten is equivalent to 1 kilogram of gluten. Whether you give 1 small toffee, chocolate, or you give 1 kg of something. I show this diagram. The same fact. Therefore, don't consume, highly restrict gluten in the diet. Then you see what happens. Once you stop the gluten-free diet and you give the gluten-free diet, you can see the series of things happen. First thing is joy on the face of the child. Generalized well-being. Immediately within 2 weeks, they will show you joy. They are happy. They are smiling. And there will be symptom resolution, weight gain, a lot of things will happen. And thereafter, you see my own study, which I published in 2007, Journal of Gastroenterology, Hepatology again. And here the effect of gluten-free diet on the growth and small bowel histology in children. Very big attainment. Now what happens? You can see here the height standard deviation scores on gluten-free diet, how they have improved following the restriction. How the weight for height has also improved. You see here the reduction in the parameter, 16% undernutrition, here 60% undernutrition. How it improves with gluten-free diet. Then see the height velocity, substantial improvement in first 1 year of life. Convincing, they become your fans the moment child has been going to different doctors, but he gets relief with your counseling, with your diagnosis is a great achievement and a great satisfaction for the doctor also. Because in small bone histology, what happens? See, over a period of years, it changes. From March grade 3B, I've shown grade 3A, and then around say 3 to 5 years, the villi has become, you see, previously blunt, flat mucosa. Some improvement, there is improvement, good improvement, and then you can see full improvement almost. Accepting some infiltration was seen in these biopsies. That may be because of subtle ingestion of gluten still in our population. So compliance, this has been shown in Delhi study where compliance in our children is young children, more than 80%. Adolescents, it gets reduced as they go to bigger classes, they go to hostels, the compliance may fall. There's the challenge which needs to be addressed. And this is how you should hold the camps. The children should be made to mix with each other. Then they feel they are not isolated, they are not single. Many other children have this kind of problem, and you can see the classes, how they are taught. This is what I was doing previously. And when the disease was seen in a large number of patients, they would also feel satisfied and happy that we are doing a good job. Celiac walk by our different societies at Delhi. Problems. Alone gluten-free diet. See, if you give processed or products, they contain high fat, refined flour, starch, fat, salt. This is all with the which are available in the market. And deficiencies occur. There may be problem of obesity, other things will occur in these patients. So what you should do, see, look at the diagram. It's a very nice diagram. Actually, when you, these blue columns here, the rows you can see here, these blue, they show standard gluten-free diet. On this, they develop deficiencies. Folate deficiency, calcium deficiency, iron deficiency, there may be many deficiencies. And when you give the alternate grain in gluten-free diet, along with that, it is not only rice-based food, then the deficiencies get filled, though the deficiency becomes corrected. You can see what are the flours that you can give: bean flour, chickpeas, lentils, soya, nut flour, almonds, chestnuts, coconut, all these things. But don't use oats. Although you will see in the books and the literature oats can be given. Don't give oats. Oats have cross-contamination. You are not sure. So better not give oats in Indian settings. How do you follow? You have to follow them. Firstly, you should call them at 1 month, maybe at 3 months, then 6 monthly. And why do you call them? One is the monitoring. Second is that how you assess the dietary elimination in these patients. That is very important. And you can assess it. One is from the history. Dietary monitoring methods are used. History, what are you saying? Mother is saying something. Then you can have the art. You should also have the art of direct questioning. Ask the child, how many chocolates do you take in a month? If he is certain, he will tell you, no, I don't take any, it is not permitted for me. So direct questioning becomes very important to assess whether the compliance. There are other methods, but I don't think you should go for clinical assessment. That is a much better way. And people just start doing TTG, IgA after 3 months of gluten-free diet, 6 months, no, don't do it. It is the cutoff values, all over the literature have shown it takes 1 year to have the levels of TTG normal. So less than 10, less than 20, although they will show a decline, but normalcy will be achieved at nearly 1 year. Therefore, waste time to save money, to be economical, best to do it 1 year rather than in between, unless you are doubting the compliance. This is the study which is showing that it takes almost a year. There may not be, there's another thing, there's the research issue, histology and the antibodies. So that is about the celiac disease. I think the messages about both the topics. Secondly, lactose intolerance is common in children. It can happen particularly younger children with persistent diarrhea and need reduction, not elimination of lactose for a brief period of time. Maybe 3 weeks is more than sufficient to correct the lactose intolerance. Hypolactasia is common in older children. So don't worry, you can take still 500 ml of milk as per the international standards. Confirmed diagnosis of celiac disease, I repeat and repeat, include histology before gluten-free diet. What happens once you have put already TTG positive and patient has been referred to, has come to another doctor. Suppose he comes to me, he's on gluten-free diet for last 6 months, what do I do? How can I confirm? It becomes a very tedious, it's a disservice to these patients. So please do histology in these patients. Don't arbitrarily treat patients with celiac disease. This is a lifelong disease. You should understand how the family suffers, the quality of life of the child suffers. So you have to be very certain about the diagnosis. Art of dietary counseling has to be learned and is equivalent to compliance. Repeated counseling for good dietary compliance. Celiac support gatherings should be made of these number of children. They feel very happy. Interaction should be there, and walks, they can also help in achieving the goals. My thanks and gratitude to IAP, our parent organization, very flourishing organization, as we have 30,000 members now. Very big one. And Global Association of Physicians of Indian origin for this opportunity. And also my thanks to Dr. Sibal, who is not possibly listening, but a good friend of mine, very bosom friend of mine, and Dr. Tandon, who is so energetic. Communication is so good. I was very happy to receive his communication. It was brief, without botheration. It was authentic and appropriate. Thank you very much to all of you.
Thank you, sir, for the wonderful talk. And I'm sure it will give us phenomenal boost to all the viewers who have watched this session. And I am also, before taking the questions, I am happy to share that apart from a very senior faculty like Dr. Rajiv Jain sir, Professor Dr. Santosh Agarwal, and other IAP senior members from Canada, from Philippines, Dr. Vinita Saran has also joined, and I acknowledge their presence. So, Tandon sir, can we start question answers?
Please do that.
Yeah. So the first question is to Dr. Anupama Chawla, madam. Madam, what is the role of PPI and ranitidine in GRD? Which is better, and what is your experience?
So I wish I could just give you a simple answer to that, but I personally do feel that an H2 antagonist, ranitidine, is no longer available to us, but we do use famotidine, which is a cousin of ranitidine. But I do personally prefer famotidine in my patients initially. I feel strongly that if at all you're going to use an acid suppression, 100% acid suppression is not necessary. It is a phenomenal policeman sitting in our stomach that does not need to be eradicated in these infants. So my personal preference, if it is not severe or to the extent of Sandifer's or to the extent of life-threatening events, I personally do use H2 antagonists. In some of my older patients in whom there is erosive esophagitis, severe obesity, definitely PPIs have a much better acid suppression, significantly better acid suppression to famotidine. And there is very often where I will begin with PPI and transition to a famotidine and wean them down. So
Thank you, madam.
that's my experience.
Thank you. And just, madam, for the viewers, there are multiple formulas available in the market. Any role of this hydrolyzed formula in GRD?
So if you look at our NASPGHAN and SPGHAN populations, and definitely, and this used to be, we used to do that in India where the goat's milk formula used to get used. And there is definitely a subset of population that I feel does benefit from a change to a more hydrolyzed formula before we go and start them on these chronic medications. So yes, there is a role of these formulas.
Okay.
Absolutely.
Thank you, madam. Madam, how much percent of endoscopies you do in a GRD, to diagnose GRD rather? What is your experience?
With experience, the more experienced gastroenterologist, I'll tell you, do less and less of endoscopy to diagnose GERD. It's only when it is refractory to treatment, or if there are extraintestinal manifestations and you want to correlate the symptoms, or if there is other things on your differential like eosinophilic esophagitis, then an endoscopy is more beneficial. But with experience, I feel people coming out of training do many more because their confidence in managing it on clinical experience and symptoms and signs is less developed yet, and it becomes less and less. What percentage do I do GERD patients? If I have 100 patients who I'm treating for GERD, I would say less than 10%, less than 10%.
Thank you, madam. Coming to Yacha sir, Anupama madam wants to know what is the incidence of celiac patients presenting with chronic constipation in India?
Yes, we had actually a study which we had done, which was the non-diarrheal presentation of celiac disease. What we found, those patients, we had a very small number of patients, 2 or 3 in that, out of 44. And for them, the typical thing was they had constipation with growth failure. And maybe in some cases there was mild anemia, but they did not have any. So we, in refractory constipation, we look at celiac disease also in India.
That's been our experience, and exponentially we are finding a lot of them presenting more with constipation. Even 2 or 3 out of your 44 would put the incidence around 8% or so.
Yes.
Which is quite high, yeah.
Sir, next question is any role of nitazoxanide and rifaximin in chronic diarrhea? What is your opinion, sir?
Chronic diarrhea, nitazoxanide is given for parasitic infestations. It is not, it may be used for GRD at times. That gives rise to diarrhea, can give rise to malabsorption syndrome, but not acute diarrhea. Only 7% of GRD have acute diarrhea.
Okay.
Regarding rifaximin, which is actually the gut sterilizer in a way, it is generally used for the hepatic purposes. And maybe sometimes, if you are suspecting very severely there is a exposure or there's alteration in the bacterial flora, you may use it, but we are not using that much. We use generally where there's a bacterial overgrowth syndrome, we may use lactobacillus. Lactobacillus is now available in India. We have good 10 raised power 6 billion units can be used, and maybe for a short period of time, but its role is not really conclusive for bacterial overgrowth. In diarrhea also there is some evidence, but not a conclusive evidence.
Right, sir. Sir, my question is, what is your opinion on Lactobacillus rhamnus or Lactobacillus retriu? Which probiotic?
We are using Lactobacillus. Rhamnosus can be used. They are marketed. Regarding the second one, that is generally propagated by the companies for abdominal pain, Ritari. But what is this? Some studies are there which are showing it may have a role, but it is not really confirmed by many other studies or large studies or this meta-analysis or randomized trials. They have not shown yet that thing. So I don't use.
Okay. And sir, some of the papers have shown some importance. What is your opinion on role of duodenal aspirate for giardiasis while doing endoscopy? Is there any role?
Aspirate, yes. I used to do it previously in 90s. Aspiration, yes. You do duodenal aspirates from with a cannula in them. You know, my friend, Dr. Shah, what is the number of patients who are on metronidazole here in India? So many patients.
So many cases.
So what we do, this giardia will not be existing at the times. I don't do stool also for giardia because it is a cumbersome process. Giardia, you need 3 stool samples, you need morning sample, it should be processed very fast, and you need to have a concentration method to detect giardia in the stool. As far as the aspirate is concerned, you may do it, but it will not yield you much. That is what I have seen. Rather, biopsy also will pick up. If there is giardia, it will pick up giardia, but you don't need to have aspiration. But if you are very keen, you can do it, but I don't feel it is very useful as compared to a duodenal biopsy for giardia diagnosis.
Okay, sir. Thank you, sir. So someone has asked for a malnourished child with a chronic constipation with a severe anemia with hypothyroidism, should one first think of a celiac or a Hirschsprung? And clinical method of differentiating
Celiac disease.
Right.
You
And
said anemia.
yes,
Well,
anemia.
malnutrition, growth failure. What we in India previously kwashiorkor, malnutrition, undernutrition was thought to be because of the nutritional deficiency. I said one of the biggest authorities in world is Carlo Catassi. He is in Italy. And he asked me for slides of celiac disease pictures, some of the patients. I sent him those pictures, he was aghast. They were looking like kwashiorkor. They were looking at severe malnutrition, but they were celiac disease patients. Therefore, I'm not saying, so from a good family, if any patient comes with malnutrition, anemia, growth failure, then certainly we have to think for celiac because the nutritional compromise will not be there. In a poor patient, where there's a problem of economy, there you may think of nutritional therapy first. But these days there's no problem. You can just do TTG IgA with a simple test from blood, and you can as a screening test in these patients.
Thank you, sir. So Dr. Tandon sir wants to ask, we see many youngsters have switched to a gluten-free diet in foreign countries, even when they have no symptoms.
That is called non-celiac. That is non-celiac gluten intolerance.
Okay, sir.
It has been there for quite some time. But their all tests for celiac disease will be negative. Dr. Anupama, you have any comment? I want your comment on this non-celiac gluten intolerance.
So I am a convert on that. I used to be
Yeah.
a non-believer of that, and I used to think this was a fad that people were really overdoing. The rich were just exploiting the gluten-free diet. But I have some very bright young children and bright young families who have nothing to gain from being on a gluten-free diet except a cumbersome lifestyle, and their quality of life improves dramatically. So I myself am a convert who has converted from a non-believer of gluten sensitivity to somebody who does believe that there is a subset that is gluten sensitive and gluten intolerant and not celiac patients.
Absolutely, absolutely. 100% agreement, and I don't think of non-celiac gluten enteropathy. Never. Never.
If Dr. Yacha agrees with you on something, you're in very good company. I was so honored to be on the platform with you, Dr. Yacha, today.
Thank you. Yes, yes, yes. But your lecture was so good. I was very, it was very impressive lecture. Very good for practitioners. This is what they want. And this is a day-to-day problem. I also face. I also learn few things from you. Please go ahead.
So, sir,
Dr. Shah, any more questions?
yeah, Dr. Khushbu has asked the clinical method of differentiating between a chronic versus persistent diarrhea at presentation.
See, persistent diarrhea basically when acute diarrhea takes place and it persists beyond 2 weeks, what we conventionally used to tell, with electrolyte imbalance, with the failure to gain weight and or loss of weight. That is what we use to say persistent diarrhea. This has been changed. Don't get confused. Persistent, protracted, intractable. Persistent diarrhea is that more than 14 days acute onset diarrhea. And with failure to thrive, that will be persistent diarrhea. Dr. Ban has done so much of work on this persistent diarrhea. And nowadays, we don't see much because we treat diarrhea very well, acute diarrhea, very well in India. Around it was 10% of incidence of persistent diarrhea. Intractable, protracted diarrhea, usually younger children, and they have infants mostly. They have got other causes like congenital lactate deficiency, Tufting enteropathy, congenital villus atrophy, glucose galactose malabsorption, all these things. But don't go into those. Those are very rare. Leave it for the specialist to diagnose. Pediatricians do not think about them.
Okay. So I think there are no
And
more.
chronic is a subacute onset. More than 3 weeks, some people take 4 weeks, some people take 6 weeks. So there's a subacute onset without any electrolyte imbalances will not take place. And they may have failure to thrive, they may have failure to gain weight. That is how you distinguish between the two, persistent diarrhea and chronic diarrhea. Acute onset is a persistent diarrhea. Chronic doesn't have. It will go on slowly increasing.
Okay, sir. Thank you. There are no more questions. And before concluding, at the outset, on behalf of all of us, I would like to express my deep sense of gratitude to all our esteemed faculties for sparing their precious time. All the viewers, Anil Tandon sir, somehow Bakul Parekh sir could not able to join because of some network issues. And if you have further any questions, I will put down on the mail. You can will answer over on a next session. I request Dr. Tandon sir to say a few words.
Thank you, Dr. Shah. And we thank the entire audience from across the globe, and we thank the senior faculty, Dr. Surinder Yacha and Dr. Anupama Chawla from USA. And they were very informative talks. And like you rightly said, very, very good for the practitioners. So we are enlightened, and we would like to hear more in the next lecture series. And we thank the audience also and the IT team, those who helped us, and the IAP platform, where many people joined from the IAP membership. And thank you very much to everybody, and have a good night and have a good day. Thank you very much.
Thank you. Thank you very much.
Thank you, sir.
Bye, sir.
Thank you, Anupama. Thank you.
Thank you. Thank you, Sayan.
So
Bye-bye.
nice to hear from you.
Same here. Same here.
Thank you very much. Thank
Bye,
you.
Chawla madam. Bye, sir. Good night.
Thank
Bye,
you.
sir. Bye.
Appreciate
Very
it.
well conducted by Dr. Shah.
And
Thank
I forgot to say thanks to Dr. Ashay and to Dr. Bakul Parekh and our EC member, Dr. Anju Agrawal, who joined from Australia, and Dr. Vinita Shan from Philippines, and Dr. Raj Velamur from Canada, and many others. I could not really note down their names, but thank you very much for joining, and thank you everybody for joining.
Thank you.
Thank you. Thank you.